Hi, and thanks for tuning in. I'm Dr. Sharif Moore of the Drug Free America Foundation, and this is the Pathways to Prevention podcast, where we discuss some of the most innovative and inspiring work being done around the world in substance use prevention, treatment, and recovery. Joining us today is Carlton Hall, one of the most inspirational and effective trainers in our nation in the area of substance abuse prevention and community change. Indeed, in the prevention community and beyond, he is known as the Tony Robbins of community change. And he's also the creator of the innovative training system known as LEAD, which stands for Learn, Educate, Activate, and Deliberate. Carlton, thank you so much for joining us.
Thank you for having me, Sharif. It's a pleasure.
So before we get into some of the more nuanced aspects of our discussion, if you wouldn't mind just sharing a little bit about your personal background and journey and how you came to work in prevention and the demand reduction space.
Sure. I would suggest that I had a bit of an eclectic background to get to where I am. I was in kind of the corporate world, corporate America, so to speak. I was working in various capacities for a good while before coming to work on behalf of the Mayor's Office of Community Services in the city of Philadelphia, where I got a chance to really engage with the beginning of my work in community problem solving and in community engagement. On behalf of the city of Philadelphia, I was the crime and public safety liaison for the Philadelphia empowerment zones, which meant I was there to connect between the mayor's office of community services, the police efforts and law enforcement efforts, and the community themselves, which really provided a real fertile ground for learning a lot about some of the issues that I would become more entrenched in our prevention and drug demand drug demand reduction efforts. And so from there, got a chance to come to the knowledge of folks like Doctors Hawkins and Catalano, who developed a process called the Communities That Care framework. They really were the pioneers of looking at risk and protective factor focused prevention models, and being able to come and work with them and learn from them allowed me to take what I've learned in the city of Philadelphia, but apply that to communities all over the country. And from there, had opportunity to come on board with an organization called the Community Anti-Drug Coalitions of America, in which I eventually wound up becoming their top person with respect to their training and technical assistance delivery system, their VP of operations, training operations, and the acting director of their National Coalition Institute. And it was during that tenure that I really became entrenched in learning about how to apply prevention tools, tactics, and resources to virtually every type of community. In counties, I worked and had the privilege of working in every state in the nation, in many counties within every state in the nation, and then internationally. And so it's been a remarkable journey that for me was filled with all kinds of teachers that really helped me to develop my own approach to the way I think about prevention and how it is that I try to apply that to communities and help them with their community problem solving efforts.
So the organization you worked for, CADCA, they work not only nationally, but internationally as well, correct?
That's right.
So what are some of the challenges you faced in trying to implement the coalition model in some of the more troubled communities in the United States?
That's a really great question. So in the U.S., we are extraordinarily privileged. We have governmental resources, money that is allocated. We advocate for, we advocate and at times lobby Congress to align and apply money for prevention efforts and even towards directly the development and establishing of community coalitions to address anti-drug efforts and drug demand reduction efforts throughout the nation. The Drug-Free Community Support program that is overseen by the White House Office of National Drug Control Policy, ONDCP, and now being administered by the Center for Disease Control, is an example of that, where here in the U.S., communities can apply for funding that is up to $125,000 a year, exclusively for the purposes of establishing a coalition to address those efforts and to do planning and to engage the broader community in their planning efforts, right? $125,000 a year from 5 years or up to 10 years. So that's more than $1.2 million that a community, a local community can have. They don't have that equivalent, of course, when we go internationally, right? And so one of the big challenges is, of course, the lack of resources that are allocated for the work of prevention in communities outside of the U.S. and particularly if we're looking at developing nations that are having some of these struggles that were taking place. And so that's one of the big challenges. But on the other side of that, when you don't have money as something that is going to attract their attention or distract them, because oftentimes money becomes a distraction, it sometimes allows folks to come together even easier, right? Because it's not about who's going to get what. It's about coming together and aligning themselves, and let's look at what is it that we can do within ourselves. But the challenge with that is that oftentimes you don't have consistency with the leadership. You don't have the opportunity to really engage in some evidence-based practices and programs and strategies that sometimes have costs associated with it. You aren't able to scale up some of those approaches in ways that can really lead to population level effect and impact. And so all of those are hurdles that we have to overcome.
So in developing countries, for instance, you've done a lot of work in Africa and Kenya and Uganda as well, correct?
Yeah.
Is it a little bit easier? Because I've worked in Southeast Asia and South America, and I know that there's a much stronger sense of solidarity and community in other countries, much more so than in the United States, where you run into a lot of individualism and tribalism even. Is it easier to get people to come together in some of the other countries you've worked in?
You know what? It's interesting. In some ways, I'd say, in some aspects, possibly yes, because I know what you're talking about. But my experience is people are people everywhere, and the challenges, the idiosyncrasies, some of the turfism kind of issues, when everybody's fighting over the same small pie of funding opportunities, and the like, that all comes out in different ways, but they are still there. What I found, though, is that very often when you find the right leadership, there are ways in which that leadership really is the driving force for setting the tone of what this agreement, what this arrangement, what these relationships will feel like. And when you have the right leadership, folks understand that everybody is contributing and investing towards a goal that's outside of their own personal interests. If you don't have strong and good and appropriate leadership, sometimes it's a little harder. It's a little more challenged, and you have to continue to work towards that. I don't think it is so much the geography of where you might happen to be. I think communities come together everywhere. I think also that there are sometimes challenges to coming together in many places. I've had some remarkable experiences though in Kenya and in other nations, but Kenya comes to mind first. So in Kenya, there are those efforts that are happening in Nairobi and in the central region of the country. It's much more urban. It's much more contemporary. It's much more cosmopolitan. There's a lot of that going on, and so the culture is completely different than when I am working on the coastal areas of Kenya, right? And Mombasa and Kwale, right? And a number of the areas that are there and where the culture is completely different. It's a lot slower, more laid back.
They're on island time.
Much more communal in the way that they engage. But man, they will pull together a rally where thousands will come out, to address the issues and speak about the issues of drug misuse and abuse for their communities in ways that are profound. They may not have all of the technical expertise that sometimes is promoted in Nairobi, the capital city, and others, but the passion and the care and the interest and the engagement is fully there, and in ways that are often lacked in the capital city, right? It's quite an interesting dynamic and combination. And what I can tell you is that I have learned extraordinary amounts of how to apply our prevention science and tools in communities from both of those communities in ways that have helped me to bring some of that learning even back to the U.S. and apply those lessons here in the U.S. And so just extraordinary experiences. The issues are raw, very often right in your face. We are talking about, for example, in East Africa and in the Kenya area, we're talking about heroin misuse that is it's staggering amounts, really challenging a great many communities. In many areas, blatant. That we're not talking about where the tourism happens. We're not talking about where the tourists go, right? Yet those challenges are often occurring because of the trafficking routes that are taking place that engage those communities and what we often refer to as the overspill of those trafficking routes, right? The residue of that takes place in these local communities that are not necessarily and have not necessarily prepared for the kind of drugs that are coming in and passing through their communities in ways that are producing challenges with addiction that they are now wrestling with to get a hold of. So a lot going on. It has profoundly changed and altered the way I think about the work that we are doing and the work that I do.
That's interesting because Kenya and East Africa, when you think of the concept of a drug hotspot, it's probably not the place that immediately springs to mind for most folks in the United States, the way Colombia or Afghanistan or, Mexico. Right. But you're saying they're experiencing significant amounts of use and addiction, probably from heroin that's coming from Afghanistan, right? It's being
that's exactly right. That's exactly right. That route that's coming through goes around that Horn of Africa, down through South Africa, and up the other end. That's often the way that takes place. And as it's going through, what the spillage is the term that I tend to use. Kind of what is kind of left off or left over, and getting into those local communities, and unfortunately into the bodies and the arms of those residents that, where they're just simply not prepared to deal with that, are creating issues and challenges that are profound in many of these areas.
Now, what's the state of the treatment system in East Africa?
Well, I've had a extraordinary opportunity in relationship with the National Authority for the Campaign Against Drug Abuse in Kenya, NACADA, which is the leading authority that deals with all the issues. They are the equivalent of our White House Office of National Drug Control Policy here in the U.S. And so they're responsible for management of all the treatment efforts. And what I can share with you is that everyone is consistently learning and applying more science, applying the latest science, applying the latest tools and efforts, and redoubling those efforts, understanding the important value of treatment and science-based treatment in communities, working diligently to try to mitigate and reduce the stigma that is often associated. And when you hear leaders, I work with an extraordinary leader in Kenya. Her name is Judy Twala, who oversees a lot of the treatment and the rehabilitation aspects for Kenya, has made it her point to emphasize the fact that addiction is a disease of the brain, and in very many of the areas, not merely in Kenya, but throughout Africa, the continent of Africa, and throughout places outside of the U.S., that's actually new information because there's a huge stigma associated with drug misuse in many communities. Many see it far more see it as a moral issue, a moral failing, and treat it as such, and therefore are not aware of the science behind the addiction issues and the disease of the brain that is really the issue and the cause. And so all that to say that they are making huge strides to increase opportunities for treatment to become available in areas where it's a challenge very often because of terrain, because of culture, because of context. They're making those strides to do that. They are improving their understanding and promotion of science with respect to these areas. But with all that being said, they still face huge challenges and walls and hurdles to try to overcome in many of these areas. And that's where the gap in the support that the government is able to offer and what the communities are able to do on their own is kind of served by the approach of a coalition, for example, and the development of a coalition tries to become that bridge for addressing these issues, and that bridge for public health and public health approach to be brought to bear for this. And so we've tried to support those kind of things. I've had opportunities while I was working with the Community Anti-Drug Coalitions of America to help to plant some of those coalitions out there since I had started my own consulting work and efforts, and working with great partners like Drug Free America Foundation. Been able to continue supporting many of these communities and efforts, and strengthen our relationships out there.
So now that you've started consulting, you've developed this very and completely new innovative training system known as LEAD, Learn, Educate, Activate, Deliberate. Can you tell us a little bit about that and how it works, and how you've implemented that in the international setting as well as domestically?
So the LEAD program that and framework that I apply really applies to the way I approach my training and technical assistance efforts all over. What it really is based upon the notion that we need deliberate practice in order to get better. It is based upon the notion that prevention is more than merely a science, but rather it is a craft, and there is a craftsmanship towards the application of prevention and prevention science. And so it is kind of built and framed on the premise that we can provide new information, new tools, help folks learn, but they have to then take that learning of that new concept, that new tool, that new practice, and apply it immediately, activate it, right? And as they're doing that, in that immediate application of that, we then go and we engage the broader community in that conversation in order to make sure that we're able to establish that in a way that can have population level kind of impact upon that. If we only work among ourselves, we're going to be very limited in what it is that we're able to achieve. If we're going to move the needle at the population level, we have to move beyond ourselves. We have to engage the broader population, which requires us to educate. Right, and to do that immediately as we are applying our work and our efforts. And the notion of being deliberate about it means that we know we're going to make some mistakes, but we know that we will get better with this whole notion of deliberate practice around it. And prevention is something that we can be deliberate about. Prevention is something that we can practice and to get better at. And so with all of the tools and all of the work that we do in prevention, I try to apply those principles in the way that I approach communities. And what I found is when I do that in places like Mombasa or places like Kwale or places in Uganda or South Africa, or even in areas in the U.S., throughout the U.S., where the language of prevention is strange, where the tools of prevention are strange, where the approach of prevention is strange, where even the notion of prevention is strange, it allows for those communities to first apply that learning to themselves and acclimate it for themselves so that it becomes theirs, so that they own it. That's the notion of it. What I tired of seeing in my more than a couple of decades of doing this work is that prevention was always presented as a scientific model that is almost presented as a doctrine. And here's what this is. And you have to now learn the new language that is associated with it. And you have all these different models and all these different frameworks. And then you take this and you regurgitate it back. And that was pretty much the process that we've used in prevention. And what I didn't see folks taking what they were learning and applying it to themselves in such a way that they were internalizing it and making it their own so they can have ownership of it. Because it doesn't, I've learned from every single model that I've been exposed to. I've learned from all the various frameworks. I've learned from them all. They all have great utility. Every single one of them has great utility. But I've taken those and I've tried to apply it. And there are those communities and those community contexts where some things work better than others, right? And then you go to another community context and there's a different kind of mix that will work better there. There's not a one size fits all approach, and there should never be a one size fits all approach. And so the lead kind of approach that I utilize allows for communities to take prevention, take the science of prevention, apply it to themselves so that they are delivering it in ways that are reflective and responsive to their own cultural needs.
And so, yes, built into it, it remains dynamic. And as you said, they can tailor it to their specific needs. And then that way, it doesn't become like stagnant, or obsolete, like so many models do. Although
or continue to be, and this is what's most important, continue to be foreign. If I come to so throughout the United States, we for many years have been applying a framework known as the Strategic Prevention Framework, the SPF, right? And so that's been a model that's been diffused. There's many other models that we've also diffused, depending on who is leading the efforts or funding the efforts or the like. But the Strategic Prevention Framework throughout the U.S. Has pretty much been established, right? Taking the SPIF, which are tools and concepts and principles that are applicable everywhere, right? So a perfect framework to take and utilize in places like Kenya and places like Uganda and places like South Africa, right? But if you cannot do it in a way that they see it as their own, if they continue to see it as a Western model coming out of the US as a US-based model, then you're going to be limited in the effect and impact that you're going to be able to have, because they're always going to see it as something that is separate from them, something that is being potentially imposed upon them, something that was never intended to fit them. And that, in my view, has limiting results that can come. So my approach was to flip that. My approach was to let them learn something, but then immediately upon learning, teach them to activate it by applying it for themselves. You translate that. You translate, how is this translated into the way that it needs to be in this small rural community in Eastern Kenya, or in this area in Uganda? So what is it that it needs to do, and how does it need to be here in order for them to make it their own? And I found much more effectiveness in applying that approach.
Now, you were recently quoted in an NPR piece on the opioid epidemic in a story about the new series Dope Sick. And I believe you mentioned the disparities in overdose deaths in communities of color, because the last 2 years, according to the data, the rate of deaths in communities of color has far outpaced that in white communities. In other words, there's more overall deaths in the white communities, but the rate at which deaths are increasing is far greater in communities of color. What do you think is causing that disparity, and what can we be doing better in the prevention community to help address that? And do you think part of that has to do with some of these models feeling foreign?
Hmm. Um, so I think yes to all of the above. I think that for a good bit with respect to the opioid crisis or epidemic, if you will, there was almost an exclusive focus on the fact that it was impacting in shocking ways. Um, White, um, often rural, often Appalachian communities that had not experienced these issues in the past, and doing it in numbers that were shocking, as has been kind of documented, and now um, um, put in the context of a story like a Dope Sick, which was based upon a remarkable book by the same title by Beth Macy, who uh, uh, researched and interviewed folks from her community in Roanoke, Virginia, and in West Virginia, and that whole entire mining community that she was kind of really, really close to, and seeing these devastating effects. Has been documented in that way. They were shocked by what was going on. And in that way, we began to talk about it almost exclusively as a crisis that was facing white, predominantly white males between the ages of 18 and 35. And that was like, what the heck is going on here? But we were doing that to the exclusion of not paying attention at all to the fact that there has always been significant issues and significant challenges in other communities, particularly communities of color, with illegal opioids such as heroin, that was happening at alarming rates and high rates, and the like, typically treated much more from with a criminal justice approach versus a public health approach. That was now the clarion call for everybody, based upon what was taking place in the opioid crisis. And so
it's a bit ironic, right? That now that it's mainly affected white Americans, all of a sudden, people are clamoring to take a public health approach, whereas during the crack epidemic, for example, which mostly affected communities of colors, it was all about locking people up.
Right. And what I believe is that many never connected those dots, right? And so whether things were intentional or not intentional, or whatever the case may be, it kind of almost doesn't matter, because the impact and the devastation, the results are still with us, and these are things that we have to overcome. But what I can see very plainly is that, no one was interested in connecting those dots, right? They were there to be connected. No one's interested in connecting those dots until now, right? And so fast forward, now that we have learned and developed in a way that said, hey, you know what, we must apply a public health approach. It's a public health issue as opposed to a criminal issue. They are now wanting to apply that more broadly to include those communities of color. There's a whole lot of distrust that has occurred during that time, right? So it's not that easy, right? We've had we've had all kinds of resources, federal resources, trying to be thrown at the opioid crisis, opioid epidemic, to engage communities, and many of those communities being communities of color, in which the response in those communities was, wait a minute. That first of all, you never tried to do this before. You were always interested in locking us up. Why should I trust you now? Or they were interested in saying, hold on a second. You're not talking about me. You're talking about that issue that, according to the news and according to everyone, was only affecting white individuals of a certain age and a certain age category. That's not us. And so there was resistance to the help that is now being applied, right? So these are communities that were always looking for help at one point, but then when help was being applied, because there was all this ignorance that was associated with the opioid crisis, and a lot of lack of knowledge, a lack of information, I believe that it increased the challenge towards engaging communities and being thoughtful about this. When the opioid epidemic started, right? It started predominantly because of the malpractice and the overprescribing practices of prescription drugs, and how those things were mishandled. And then that later evolved into a heroin crisis in communities where a heroin crisis never showed up in the past, right? And so now that's what's really causing the alarm bells to go off. But we have had communities where the heroin crisis was always an issue for the last, 20 plus years, right? If not longer than that, right? And so the notion is, okay, where does the parity come in, and how are we able to address that? I believe that we are getting better about that. I believe that the conversations are now beginning to change in very positive ways around this. I believe that there is a good and well-intentioned effort to recognize some of those deficiencies that we've had in our systems in the past, and voices like quite frankly, yours, Dr. Moore, and my own, and others who have been kind of raising these issues with opportunities that we've had to raise these issues. I think that some things are beginning to change. I think that change is happening slowly, but we're committed towards continuing the fight.
Amen. Slowly but surely, one day at a time.
Amen to that.
And thank you so much, Carlton, for coming on, and also for the amazing work that you're doing, and just being so active in promoting this most just cause.
It has been my pleasure and privilege to be here. The Drug Free America Foundation is one of the premier organizations in our country. And it has been a privilege and an honor to have some opportunities to work alongside of you all. And I have a deep and profound appreciation for your work, Dr. Moore. Thank you so very, very much for who you choose to be.
Thank you. And for anybody that wants to learn more about Carlton and his work, they can go to his website, www.carltonhallconsulting.com. You can learn more about the Learn model as well. Thanks again, Carlton, and I hope to collaborate again in the future with you. Take care.
I look forward to it. Take care, my friend.
And thanks again to all of our listeners, without whom this podcast would not be possible. And also, we'd like to extend our thanks to the Adelson Family Foundation for their generous support of this podcast. Until next time.